shoulder pain is coming from the neck or if it's coming from the rotator cuff. First, I'll get an MRI of both the neck and an MRI of the shoulder.
Okay, first off, for those that are watching, thank you, but this is probably the worst advice that I've ever heard someone give. Not only do you not need an MRI, it's definitely not the easiest and or simplest, fastest way to check. We will show you a much better way that's free. I mean, we're talking 2 MRIs, one of the shoulder, one of the neck, easily $4,000 worth of MRIs. And if you're watching from a different country, UK, Australia, Canada, anywhere else in the world that has some kind of socialized medicine, you might wait 6 months to a year to get an MRI. So that is not the easiest way to do it. In fact, there's a much better way.
Yeah, history and clinical exam should be done first. Imaging are adjunct to the clinical history and the exam. You match them together, and then you make a clear clinical picture.
And a lot of times imaging, we don't even need to use that unless there's some kind of red flag after the clinical exam. But I mean, he's going to pick MRI because then he doesn't have to spend more than 5 minutes with you. That's the first thing they're going to do because it's a way to get you in and out of there quick. When if you actually sit down and take 20, 30 minutes with someone and do a full exam, history, physical, baselines, all those kind of things, you can usually figure it out pretty easily.
Shoulder looks bad and the neck looks good, it's probably your shoulder. If you have something where both the neck looks bad, as in a pinched nerve, the shoulder looks bad, clinical exam.
What's bad? What's good?
Clinical exam.
Yeah, that's the only thing you said that's worth anything.
You also get something called an EMG or a nerve conduction study to see if a cervical
stab you with more needles. Yeah.
Another easy test you can do is a steroid injection.
Easy for who?
Thousands,
easy for you.
Thousands.
Yeah.
It's very likely coming from the shoulder.
Easy for you. You're doing the stabbing.
Say it takes away some of your pain. You still have the shooting down pain. Which one to treat first? Kind of depends on your spine surgeon. Depends on how much spinal cord compression you have.
All right, so the only thing in that last clip that he said was worth any value was, like what we talked about earlier, the clinical exam. That is what should be done first, and it's what you should dedicate the majority of the time on, not talking about getting more tests, EMGs, steroid injections. I mean, easy for who? He said it was easy just to do a steroid injection. That's not easy to get your shoulder stabbed with a needle.
Expensive and unclear. You can determine almost all that from an exam and not have to go through those, wait for the test or wait for the results and then actually get the test.
Yeah. The other thing that was interesting is he didn't elaborate on what a good MRI or what a bad MRI looks like. The fact is that test is highly sensitive to everything. It just shows a lot of stuff, but it has very, very poor specificity on what's actually causing any kind of symptoms. So if you're, 44 years old like me plus, and you were active, you threw a ball, you were active in sports, lifting weights, the chances that you have something bad or scary that looks on an MRI, very high.
Yeah,
and
almost guaranteed.
Every decade after that, 50s, 60s, 70s, you're guaranteed to have some kind of degenerative joint disease, disc disease, arthritis, stenosis. That's all going to be in there, but it doesn't mean that it correlates to any of the symptoms you're having.
You may have no symptoms at all, even with those positive findings on a picture. Same thing applies to the neck. If you have degenerative changes, osteophytes, disc degeneration, or disc herniations, sometimes those correlate, sometimes those don't. A lot of people have those findings and they have no pain or no symptoms at all.
The other thing that was interesting at the very end there, before I stopped it, he talked about spinal cord compression. There's nothing having to do with your spinal cord compression in this scenario. He's talking about neck or shoulder pain, which is unilateral, one side.
Nerve root.
If you had cord compression, you'd have symptoms on both sides, arms, legs, the whole thing from the neck down. That's a whole different diagnosis and a whole different problem.
Yeah.
Depends on how much spinal cord compression you have.
You have no spinal cord. It's a root.
First, also is just a long discussion with both your spine surgeon and shoulder doctor. Should be colleagues, friends, kind of have a plan together.
Okay, so that was the last part of the video. Like we talked about just before, there really is no spinal cord compression. That's a whole different, area and problem that we're not even going to talk about in this video. This is all about the nerve root or peripheral. Okay, so what you can do, you do not need to go see a spine surgeon or your ortho surgeon for your shoulder.
No.
Yes, that is an option, but we're trying to give you a different option and save you a bunch of time and a bunch of money.
Yeah.
It's easy to determine where it's coming from based off a couple of things. Jake, where would we start in the sense of, let's go back to that. The only thing they said that was even remotely good advice was the clinical exam.
Yeah, so no matter what, we need to take a history and an exam. So we understand the full picture and we have an accurate idea of what is producing your symptoms, what is affecting it, and what is changing it. From there, we can get baseline movement. So in this case, we're talking about the neck and shoulder.
Shoulder pain.
We'll start with range of motion of the neck, range of motion of the shoulder, and then any other audit we can find. So this is anything that you know reliably produces the pain.
Mhm.
So in this case, it might be lifting something up overhead, putting something on top of a shelf. Those will be tests that we will test against. So once we have those baselines,
Mhm.
we can perform any intervention, any treatment, and then we will retest those baselines immediately following that to see, are we making positive changes, are we making negative changes, or are we not changing it at all until we find movements or positions that affect the symptoms in a positive manner.
Yeah, and we're going into those baseline testings with an idea already based off of the history that we talked about. So we'd go back to, what was there a mechanism at all that started this shoulder pain?
Yeah.
Did you fall? Did you pick something up and all of a sudden, like you could feel something, right away pop or you
tear.
knew something happened? Or if that's the case, then we're thinking, okay, we're going to lean a little bit more towards shoulder at the beginning. But if your history is, no, I just woke up and all of a sudden I have this like pain in my arm, and it can be there when I'm sitting, it can be there when I'm moving it. Like, we have to take all those things into consideration. So the first thing is just how did it start and any kind of mechanism. Second would be, the body diagram to describe to us where you feel it. A lot of times when they go into the doctor here, all they're saying is my shoulder hurts, and they don't even look
where's
like
the shoulder?
where else.
Yeah, what do you mean shoulder?
Could you mean like your trap hurts? Could you get any kind of shoulder blade pain or down the arm pain? Even if that's temporary, right? Maybe the constant pain is here, and I occasionally get some burning or something down the arm.
That's huge.
Then our scales
Neck.
already switch from like 50-50, 60-40 to like 90-10. If that's the pattern, you already know confidently it's neck. Then we're going into our repeated movements and baseline checks to prove that it's not, right? We're going to make sure that it's not that, and we're going to start right there with the neck, based off of that finding or that information that you're going to give us. But for him to do that would actually take time that he'd have to sit down and ask you questions and dig more into than just looking at, getting you scheduled for an MRI for 2 places. So then after that, like Jake said, we would take some baselines, right? How far can you lift it? All these kind of things. And then we think about the mechanism behind that and the structures. If it's a muscle tendon issue, like in the shoulder, you should not really have pain at rest. The pain should really only come on when you're lifting things. Yeah, like if I take his arm and I lift it, it shouldn't really hurt because I'm providing the muscle for that.
But if
he does it, if I resist, a lot of pain.
That would be muscle tendon.
Right? So then that's one thing we can look at. The other thing is, well, if he has a loss of motion, right? Muscle should not have a loss of motion. Loss of motion in certain directions, any kind of pain pattern in the trap or in the arm, we're instantly thinking neck. And we would start there, and that's how we would compare the baseline. So we would start with a neck movement, usually a retraction extension, a protrusion, a flexion, something that then we'd go back and test. So we started with here, all I could move it. I did a bunch of these. Now all of a sudden my arm moves to here. It has to be neck. That's how easy it is to determine where it's coming from. If you fully exhaust all of the directions and motions here, and it's no different, then it's not the neck. Move to the shoulder, then it's the shoulder.
Yep.
That's how easy it is.
Yeah. Clear as day.
Thank you.